So let's now transition to side effects of trimodality therapy. And so why do trimodality therapy? Well, one reason is the potential, maybe up to 85% chance of keeping the native bladder. Certainly that is a very good reason. And the thought is that, well, maybe quality of life could be better with trimodality therapy. And so some studies have tried to look at this. There's a number of studies that have looked at toxicity rates. And whenever we talk about toxicity, grade 3 or higher toxicity is considered significant toxicity. So if we look at cooperative group and UK trial experiences, the chance of having late pelvic, meaning GU, bladder, or urinary related, or GI, bowel or rectal related toxicity in the long term is actually pretty low, under 10%. And there was also a quality of life study done that tried to compare trimodality therapy to radical cystectomy, and it suggested that patients who went through trimodality therapy had markedly better sexual quality of life. And that is a consistent thing that's found in different studies. There was also the feeling by patients when, again, compared patients that went through cystectomy versus trimodality therapy, they all filled out these questionnaires. And the ones who went through trimodality therapy were scoring also higher in terms of feeling that they had better informed decision-making in their treatment choices. There was less concerns about appearance and less life interference from cancer or cancer treatment. Perhaps surprisingly, there were similar urinary scores. One would think, well, you get to keep the bladder, so urination should be better. The truth of the matter is patients adapt very nicely, usually, to urinary diversions that are done with cystectomy, whether it be a neobladder or an ileal conduit. And so patients adapt, generally speaking, very well to that. And so that explains probably why urinary scores were not different between the two treatments. Sometimes in the world of quality of life, there's this thing called doing decision analyses to look at something called quality adjusted life years. So if one treatment offers better quality of life, and if survival is the same between the treatments, how much better is it? Can that be quantified to some degree? And there's this technique called doing decision analyses, and a quality adjusted life year means that for that period of time extra, you live in a perfect health state. And when comparing all trimodality therapy patients to radical cystectomy patients in this one study, it suggested that for 0.6 of a year, so almost 2/3 of a year, there was better ideal health state of life. When comparing very favorable patients, meaning the patients with the least aggressive cancers, a small T2 tumor, in very favorable cases to very favorable cystectomy patients, that number of quality adjusted life year went even higher to 1.6. So there is some suggestion in studies like this that quality of life indeed may be better between these treatment modalities. Leading some to say the best bladder you'll ever have is the one you're born with, even if it's had an aggressive resection of the tumor and some radiation. Now, I have to say, again, many patients who go through radical cystectomy do very well and don't have major complications and adjust to the cystectomy and the urinary diversion and have excellent quality of life. So, and the studies that I've presented are by no means definitive. They're just suggestive. And by that, I mean there has never been a randomized trial between cystectomy and trimodality therapy. And that would be, of course, the gold standard of comparison, but it's never been able, no one's been able to ever pull that kind of study off. They tried in the UK, but unfortunately the study didn't accrue sufficiently, didn't bring patients into the study at a sufficient rate to warrant continuation of that study, so it was closed early. So all the data I'm presenting to you has some limitations and by no means is definitive. So if one spares the bladder, first of all, the important thing is to note that since the bladder is still there, it needs to be surveyed cystoscopically, and that needs to go on lifelong. 25% of patients who have gone through chemoradiation trimodality therapy for their muscle invasive bladder cancer may develop a non-muscle invasive recurrence. Now, the good thing of non-muscle invasive recurrences is that they could still be managed conservatively with another resection and perhaps BCG, and that overall data suggests that those patients can be treated in that way. It's tolerable, the toxicity is acceptable, and outcomes seem to be acceptable as well. So even if one is part of the 25% that may develop another non-muscle invasive recurrence, that could still be managed conservatively. In this slide, what we looked at is in those patients, remember 10 to 15% may still need a cystectomy for salvage because of a muscle invasive recurrence after trimodality therapy. And so we looked in this study at comparing those patients at MGH that required a salvage cystectomy after trimodality therapy versus those patients at Memorial Sloan Kettering who went through a primary cystectomy, meaning they didn't get chemoradiation, they went straight to cystectomy initially. This is actually from the data that I showed you earlier regarding the morbidity from Memorial Sloan Kettering. And again, if we focus on grade 3 to 5, what you can see is the numbers 14 and 11, 2 versus 0, 2 versus 2. Yeah, it's a little bit higher for the salvage cystectomy, but many would argue it's acceptable and that these are relatively, that these are acceptable rates of toxicity for salvage cystectomy. So yes, going through a cystectomy after chemoradiation can be harder. It can be a bit of a harder surgery. And it is important to note that there is not really a big experience in doing neobladders after chemoradiation. So the usual urinary diversion after trimodality therapy, if a cystectomy is needed, the usual urinary diversion would be an ileal conduit, not a neobladder. But even so, patients who go through this seem to do reasonably well in terms of the toxicity rates. Okay, so now let's look at guidelines. So what do national guidelines say for trimodality therapy? If we look at the NCCN guidelines, these are the major guidelines that inform oncology care in the United States. For stage 2 bladder cancer, that's a T2 bladder cancer, muscle invasive, chemoradiation is listed right along with, as you can see up here, cisplatin with a radical cystectomy, so neoadjuvant chemo and a cystectomy is a category 1, but listed right along with it as a category 1 recommendation is chemoradiation or trimodality therapy. This also applies to stage 3 bladder cancer, which is a T3 tumor or one that has a regional lymph node involvement. Their chemoradiation remains a category 1 recommendation. If we look at advocacy group guidelines as well, if you look at Urology Care Foundation, chemoradiation trimodality therapy is a discussed option. If you look at Beacon, There's a statement that bladder preservation with chemoradiation is suitable for those that meet the requirements. Even the AUA guidelines list chemoradiation. So this is the American Urologic Association guidelines list chemoradiation as an option. Now, there are many trials that have occurred over time, over the decades with trimodality therapy. It has a long track record. And here I just wanted to highlight a new trial that's opening that is national. It is being co-led by two of the large cooperative groups, SWOG and NRG. And this is for patients with muscle invasive bladder cancer. And in this case, they are all receiving chemoradiation or trimodality therapy, but they would be randomized to receiving, along with chemoradiation, atezolizumab, and that is an immunotherapy. I'm sure many of you have heard a lot about immunotherapy, especially in bladder cancer. And so this study is looking at whether or not adding immunotherapy to trimodality therapy improves outcomes, improves survival. And so this study will be looking at that and is a good one to be aware of. Ultimately, our hope is, as clinicians, as scientists, we hope that we can inform the patient decisions and choice of treatment more intelligently. And that goes towards a biomarker-driven management of muscle-invasive bladder cancer. So if all patients that have muscle-invasive bladder cancer are seen truly in a multidisciplinary clinic by all the specialists, urologists, radiation oncologists, medical oncologists, and we look at the factors, the clinical factors, et cetera, associated with that diagnosis for that individual patient, but we also bring in biomarkers, and maybe they can help us predict whether some patients would do better with trimodality therapy or some would do better with cystectomy. That is the gold standard. And then also using biomarkers in follow-up. So I think a lot of work is going towards trying to implement this paradigm in bladder cancer. There's some examples of biomarkers. This one's called MRE11, where if you express MRE11 in a high way, a high expressor, you seem to do better with radiation than if you're a low expressor, and it doesn't really matter if you're getting a cystectomy. So again, maybe here's the inkling that MRE11 high expressors could do particularly well with a trimodality therapy approach. And there's other new work that's looking at the immune infiltration of the tumor and whether or not there are improved outcomes, again, with trimodality therapy compared to radical cystectomy. So there's a lot of work going on with these sort of biomarkers. So in 2019, and this wraps up my portion of the presentation really, I strongly believe that patients should be offered trimodality therapy. Not all patients are good candidates for trimodality therapy. Those patients that have diffuse or extensive CIS, carcinoma in situ, those that have bilateral hydronephrosis, those patients that maybe have very advanced local bladder tumors, maybe T4 tumors. These cases may not be ideal for trimodality therapy. Similarly, patients that have very poor bladder function may not be great candidates for trimodality therapy because trimodality therapy isn't going to necessarily improve the bladder function. So sometimes patients like that are better served by a cystectomy. So there are certainly a number of situations where patients may not be ideal for trimodality therapy. That needs to be discussed though with the patient. And in clinically matched patients, patients that are similar and that are good candidates for either, it does appear that survival is comparable between trimodality therapy and radical cystectomy in the modern era. And in those good cases, 85% of patients will keep their own bladder. And the quality of life data suggests that that's probably better than urinary diversions. And the long-term quality of life looks pretty good in these patients, as we went over. We also have to emphasize and also remind our urologists that this is not a non-surgical treatment. That surgery is very important. The TURBT is an elegant procedure and operation, and a salvage cystectomy may be needed in 10 to 15% of patients. And these are very important components to the success of trimodality therapy. We should know that trimodality therapy is supported by numerous guidelines, even as a Category 1 recommendation in the NCCN. And ultimately, I think we need to continue to advocate for multidisciplinary engagement. All muscle-invasive bladder cancer patients should meet with a urologist, a radiation oncologist, and a medical oncologist, in my opinion. This is a complicated disease that often needs multimodal therapy. Even if one's going for a radical cystectomy, there's the discussion of whether or not neoadjuvant chemotherapy should be included. So I believe that all the patients with muscle-invasive disease should see specialists in all those disciplines and therefore make informed decisions. Because ultimately, as I wrote with a resident of mine in this article, safeguarding the autonomy of patients with bladder cancer is critical. And informed decision-making by the patient is key once that patient is provided all the facts. And we need to rid ourselves of biases that are, specific to one discipline of medicine versus another discipline, and we have to let the patient be autonomous and be allowed to make an informed decision that they feel is best for themselves. And with that, I will end my component of this presentation.
Thanks. I don't know if I have the controls now or not, Stephanie. Do I have control over it? Great. Okay, so I'll pick it up from there. Thanks so much, Jason. That was an awesome overview of the standard of care in bladder preservation today. I just want to finish up by sharing a few thoughts of some of our observations regarding what I would just call a change in plan on cystectomy. So as many of you know, about 15, 16 years ago, patients facing cystectomy started to pursue neoadjuvant chemotherapy, which means chemotherapy prior to cystectomy, which might be thought of as bimodality. And in many studies, those patients were found at the time of cystectomy to have no cancer. This quote really sums it up as far back as 1998, when Dr. Herr at Memorial Sloan Kettering said that in patients who had achieved a status of not having cancer after neoadjuvant chemotherapy, the vast majority of them who kept their bladders would actually remain disease-free and keep their bladder for a long time. These were people who were actually intending to have a cystectomy. And since that time, we've analyzed some of our patients at Columbia who have finished neoadjuvant chemotherapy with platinum-based intravenous chemotherapy and had muscle-invasive bladder cancer. And prior to having their bladder removed, were actually noted to not have cancer in their bladder. And in a group of patients that we reported on just earlier last year, after 48 of those patients, 41 of them essentially decided not to undergo an operation. And those patients had biopsies that indicated no cancer following chemotherapy. And over time, we followed those patients very closely with cystoscopy, urinary tests, CAT scans. And in that group, the neoadjuvant chemotherapy was sort of the standard treatments, including MVAC or Gemcis, gemcitabine, and cisplatin, and we followed them for up to about 3 years. And the results in our own group, on the next slide, see if I can get it, actually showed that the cancer-specific survival on the right side of the slide was in the high 80% range, and about 60%, 58% ended up never having cancer again in their bladder or outside their bladder. So not a perfect cure rate, but a relatively high rate of cancer-specific survival. And similar to the trimodality therapy, some of these people ended up having a delayed or salvage, if you will, cystectomy later on. And at 5 years, about 79% of the group was predicted to not have had their bladder out. So some who relapsed actually did end up having superficial relapses in the bladder that could be treated with a TUR alone. And since that time, we've subsequently gone on to combine the data that we have on this with the group at Memorial Sloan Kettering, and have looked at a larger population of patients with the same phenomenon, a total of 148 patients, and essentially found somewhat similar results. If the patient pursued cystectomy, preceded it with chemotherapy, at the end had no cancer on cystoscopy and elected not to go through with the bladder removal surgery, that a reasonably fair number would have a durable disease-free survival. And we even looked a little further to determine some of the things that might predict that. And in fact, that carcinoma in situ that Jason mentioned earlier was one of the biggest predictors of relapsing in the bladder, that those patients had a higher risk of relapsing in the bladder, and the presence of an obstructed kidney or hydronephrosis was a strong predictor of relapsing in the muscle wall of the bladder in the future. We've gone back and reviewed a lot of the world's experience and published a meta-analysis, a review of all the trials doing this within the last year. And there have been many studies that have tried to review the combinations of chemotherapy and cystectomy. And we found about 10 publications that included over 250 patients that would describe what would happen to people who had no cancer at the end of chemotherapy and decided not to go through with cystectomy. And that trial is a little small here on the table, but basically looked at people ranging in age from 55 to 81, all of whom had muscle invasive bladder cancer prior to starting the chemotherapy, and showed that overall there was a 72% 5-year survival, and that the median follow-up there was anywhere between 4 months to 120 months, and the overall risk of doing this in terms of comparison could not really be determined from the study because none of the patients had trimodality therapy or cystectomy, but all had reasonably similar outcomes to patients with residual cancer treated by cystectomy. So that's just a whirlwind tour through sort of a non-standard and emerging therapy that's really been born out of the concept of preceding cystectomy by using platinum-based chemotherapy, and then realizing that in certain very specific situations with a very tight screening process, you can identify some patients who don't have cancer and try to spare them the cystectomy that they were intending to do. So I'll stop there. Maybe we can open it up for questions.